And welcome to our Infant Health Equity Virtual Town Hall. Today we are kicking off a series of presentations and information that will help guide you through some really important information and facts around what Healthy Start and our Healthy Start community is doing to improve infant vitality and eradicate some of the disparities that we face in our region. I'm really excited today because not only do we have Latasha Mays to give our keynote, but we have presentations from community members who are doing really important work in Allegheny County and beyond, and who will share to give you context around what we mean by infant health equity. We'll get a little bit more into the project that we have going on and the action plan that we're creating that will help impact the disparities in Allegheny County. But before we get into that, I want to announce our keynote speaker. Our keynote, Latasha Mays, I think, most of you, if you're not living under a rock, have heard of Latasha. But I'm excited to have Latasha with us this morning because she is a dear friend and a sister, and definitely one of the trailblazers in the area of reproductive justice. So I'm going to read her bio, and then we'll get into Latasha's keynote. So Latasha D. Mays is the founder and outgoing president and CEO of New Voices for Reproductive Justice after 18 years of leadership. She is a respected national leader in the movement for reproductive justice, longtime community organizer and policy advocate for Black women, femmes, girls, and gender expansive folks at the local, state, and federal level. Latasha and New Voices began their work for the Black maternal health when confronting the Allegheny County Jail about the shackling of pregnant, incarcerated women and the death of a pregnant woman, Amy Gillespie, who died from a preventable condition over a decade ago. For the past few years, Latasha has led New York Voices in centering Black women, Black mamas, and birthing folks in policy and advocacy, and working directly with Black maternal health organizations like Healthy Start, through the COVID-19 Community Relief Initiative that served over 3,000 Black women and families across Pennsylvania and Ohio, and now through gun, domestic, and gender-based violence with the Say Her Name Justice Fund. Latasha recently announced her candidacy for elected office and was just named City and State of Pennsylvania Power of Diversity 2022 Black 100. Again, I'm so honored and excited to have Latasha join us this morning and give our keynote. I'm so excited to have Latasha back in Allegheny County, and I believe that she's going to be here serving us for a while, and I'm excited for that, and I'm hopeful for that. So Latasha, take us away, please.
Good morning, Healthy Start. Happy Women's History Month and happy Women of Color Herstory Month as we celebrate in New Voices. Thank you, Jada, for such a great introduction. We have such a long history together in Pittsburgh, trying to create a just and a justity for all people. Thank you for this opportunity to participate in this important town hall about infant health. And thank you, Jada, for your leadership to advance Black maternal and child health and reproductive justice in the greater Pittsburgh region. Once again, my name is Latasha D. Mays. I am president and CEO of New Voices for Reproductive Justice. We have some big changes going on in our organization as we move into our next chapter. I will be transitioning out of my role in the next few weeks as I move into my next chapter. I am grateful that one of my last speaking engagements will be today with Healthy Start, a longtime partner in crime, partner in action to improve the health and well-being of Black mamas and birthing folks and Black people when we want to bring our children into the world. I've had the honor of serving in the leadership of New Voices for the past 18 years, and we have a fierce mission to build a social change movement dedicated to the health and well-being of Black women and girls. We have had a bold social impact goal that Black mamas, Black women, Black femmes, Black girls, and Black gender expansive folks in Pennsylvania, Ohio, and beyond that we get to live long, healthy, and joyful lives. Some of you may be familiar with my work in New Voices for almost 2 decades, but I always like to ground any speech or presentation in the meaning of reproductive justice. And everybody knows me, I'm always going to talk about reproductive justice, no matter where I am, no matter what space I am. And again, as we move to fight and win concrete changes in the lives of those that we serve, I'm always going to talk about reproductive justice, and that will never change. Reproductive justice was created by 12 Black women in 1994 who birthed a movement that has changed the world. Reproductive justice is a movement led by Black, Indigenous, and women and folks of color. Reproductive justice includes reproductive health and reproductive rights, but it is not interchangeable. New Voices defines reproductive justice as the human right to control our bodies. Now, if this was a rally, I would do call and response and you would say our bodies, our sexuality, our gender, our work, reproduction, and the ability to form and keep our families. Reproductive justice is about all the decisions a person has to make on their reproductive journey. Our work is intersectional, which means in the words of Audre Lorde, that we cannot have single issue movements because we don't live single issue lives. We also define health as physical, emotional, spiritual, and cultural, as well as political, economic, environmental, and social well-being. To demonstrate this point and the depth and breadth of the RJ work that we do, the reproductive justice work that we do right here in the Pittsburgh community, includes hosting Black Maternal Health Week in both states and all 3 cities, and supporting the national efforts of Black Mamas Matter Alliance as a movement partner. Black maternal health is one of our 3 priority issues in New Voices. And for so many years, we've had the opportunity to work with fierce Black women who are doing this work on the front lines, like Healthy Start here in Pittsburgh, like Oshun Family Center in Philadelphia, and like Birthing Beautiful Communities in Cleveland. We have also worked with state and local policymakers and other advocates to not just study infant and maternal mortality, but for us to intervene and disrupt the cycles that put our families and children in this position in the first place. That we are confronting systems and institutions that continue to yield disparate health outcomes for Black babies, Black mamas, and Black birthing folks. How I know the power of reproductive justice when it comes to infant health and maternal health is that during COVID-19, which we are still living in a pandemic, we are still living in a health pandemic, even though some folks would like to think that we are not. What I saw and what New Voices witnessed in real time was that there were so many gaps in services, in resources, and that it really exposed that our families that are already on the social, economic, and political margins were even deeper into that experience, into that lived experience. As an organization that really focuses on community organizing, policy advocacy, leadership development, and culture change, we had to shift everything about New Voices to serve Black mamas in a way that was more concrete, in a way that people could touch and feel, that there was support that was needed right now, today, and it changed the DNA of our organization. So when we started our COVID-19 relief initiative, we had no idea the demand that we would have, because it was so crystal clear that when we fight for justice, we also have to make sure that we can help connect people to the resources that they need to get their basic needs met. And that was what was so powerful about the COVID-19 moment, and really push new voices, push the reproductive justice framework to not only talk about kind of ideas that are long term, but what could we do today that demonstrates reproductive justice? So, in serving over 3,000 families, again, right here in Pittsburgh, the greater Pittsburgh region, and so I cannot tell you the number of cities we served in Western Pennsylvania with our COVID-19 relief program. We were able to provide free diapers and menstrual products. We were able to provide $40,000 in cash grants. We were able to provide new mama baskets to new Black mamas and birthing folks, yoga memberships in partnership with Yoga Motive here in Pittsburgh, free emergency contraception, free laundry services in all 3 cities, and toy drives for the holiday. And since April 2020, we've moved over $400,000 directly back to our communities because that's what our communities needed. And so we now employ a bread and roses approach. I can't ask you to fight for justice if you need diapers, if you need rental assistance. And so that's what we were able to do. And again, that is the intersectional transformational power of reproductive justice as a movement, as a framework, but also as a practice. And that was such a powerful time in New Voices, and continues to influence how we engage Black mamas in our work, who are more at the center of the work that we do, because we know that Black mamas are first and most impacted by so many of the issues that New Voices is addressing in the justice realm, in the policy realm, in the organizing realm. And so we've been able to grow a base of Black mamas and folks who are like, New Voices is not only just showing up for me when it's time to vote, but they're showing up for me when I'm in need. And that has been a great evolution of the work of New Voices. Addressing environmental racism with our Black Women Green Future campaign and programming, we're making the connection between the womb as the first environment and maternal infant health outcomes. And especially when Black and brown and poor communities have the greatest proximity to toxic waste and industrial facilities, and, you know, are really impacted by so many environmental issues in communities across this region specifically. We're also developing the next generation of reproductive justice leaders through our Sister Speak Youth Project. So they are fighting for their own human rights. They are fighting for reproductive justice, advocating at the state level for comprehensive sex education, learning about the importance of Black maternal health. And that was something that they asked to do. They asked to understand. We had young mamas who are part of Sister Speak, who these are our leaders. They will become our organizers and activists and the leaders to take our place. And so that's just some of the work. That's some of the work that we are doing in Pennsylvania and in Ohio and across the Rust Belt. So if the impact that we want to have, the impact we want to have is the intersectional effort of so many of us who are here today. Some of you are birth workers, your doulas, your midwives, your healthcare providers, your community educators, your Black mamas yourself. And it also takes the organizers, the policy advocates, and the fighters to move the politics and the culture to prioritize infant health, to prioritize maternal health. We cannot be singularly minded in reproductive justice. It's all about the layers. It's all about the complexities. And it's a hard road to get to our destination but when we get there, we want lasting and enduring change for our health and well-being for Black women and femmes and folks and mamas, as well as our families and our communities. So for me, I hope all of this means that as we go forward, we're employing a lens, a framework, and most importantly, a reproductive justice practice in the work that we are doing in our organizations, in our outreach, in the actual services we provide, so that we can serve Black mamas and birthing folks to the fullest. If we look at reproductive justice in its most basic framework, we all get to decide if and when we will have children, if and when we don't have children, and how we raise our children with the social supports that we need in healthy communities that are free from all forms of violence. That's the original reproductive justice framework. So as we look in, as you go forward and as you have these conversations and you're looking for answers for why things are the way that they are, I have the answer for you. The answer is white supremacy. The answer is racism. The answer is gender injustice, economic injustice, and patriarchal violence. Black mamas and birthing folks must be at the center as we disrupt and dismantle all of those forces in our community and forces in the world that put us in this current position. I want to end my comments there. I hope you have an amazing town hall today and tomorrow. Thank you so much, Jada and Healthy Start, for this opportunity to share about the work of reproductive justice and new voices for reproductive justice. Please, I ask for your support as we bring in our new executive director, Kelly Davis. Please show her your love. Please show her how we move, how we organize, how we win for Black mamas and birthing folks, how we win for reproductive justice. And please follow us in our work here in Pittsburgh, across Pennsylvania and Ohio, and across this country. I thank you for your time. I'm grateful to be in this space with all of you. Thank you, Jada, and thank you, Healthy Start.
Thank you so much, Latasha, for your powerful words and for your inspiring words, and for allowing, for making the time to keynote for us as one of your last keynotes in your outgoing role as president and CEO of New Voices. And you really touched on the importance of coalitions, the importance of partnership, the importance of organizing, and the importance of centering the voices of Black mamas in this conversation, and in our quest to find solutions to the problems that you so poignantly and eloquently stated that are right in front of us. But then also how intersecting it is not one identity. It's not about one identity or about one issue. It's about all of these compounding issues that get us to where we are today, which is why I'm so excited again for the presentations that our community members and mamas are going to share, because they're really doing important work to address the urgency of what's going on in our communities now, the urgency of what our families need now, while also being focused on the future and on what we need to do at community and policy levels. So now I'm going to introduce Mrs. Elise Pinchback Johnson of Pinchback Consulting. Elise has extensive experience in managing community engaged processes and was brought onto our project to get us through this action planning process. We had a tight time frame to engage community, to engage some of our core stakeholders. I thank those folks for all of their dedication in the last few months in working through this process with us. It's been a very intensive process. We're still in the thick of it, but we have identified what we believe to be the local priorities around infant health equity that contribute to our action plan. So Elise has been guiding us through that process, also with support of another consultant, Venu from Pop Health out of Northern Virginia. And they have been a dynamic team, again, bringing us through synthesizing some really complex issues. It is not a single issue. Again, we're looking at workforce issues. We're looking at what the care that our moms receive. We're looking at the environments and the communities that they live in. So very complex issues that we're working to synthesize down to some priorities that we can actually take action on locally. And in 5 years from now, we envision a different reality for moms and babies in Allegheny County. So Elise, so excited to have you break down the rest of our project so that our community understands where we're going, how we intend to get there, what the process looks like, and how they can contribute to the process. Elise?
Good morning, everyone. Thank you, Jada, for those words, and thank you, Latasha, for your continued leadership in the reproductive space. So I have a few slides that I want to go through in these next couple of minutes to get us oriented to the project. There will be time at noon to talk a little bit more deeply about the project. So please stick around to hear more about some of those priorities at noon. So if we can get those slides up, there we go. We'll go ahead and get started. So we'll go ahead and go to the next slide. So the Infant Health Equity Project is a national project. We are one of 21 Healthy Start grantees around the country who received funds to do this work around reducing disparities in infant mortality. And so the goal of the project is to create a local action plan with data-driven policy and strategies. And we're looking beyond those medical factors and really thinking about the conditions that affect infant mortality disparities. So poverty, education, housing, nutrition, a lot of the things that Latasha mentioned in her keynote and the things that we know, see, and experience on a regular basis here in the region. Our plan will incorporate input from our community members, also existing maternal and child health strategy processes in Allegheny County. So if you saw in that first slide where it said phase 2, it really is the second phase of a project. This team has been doing this work for a couple years at this point and did a great job in phase 1 of really laying the foundation and doing an analysis of the ecosystem. And now we're building on that work for the action plan. You can go to the next slide. So our project structure has 3 parts. We have our core team. We have the coalition that's doing the work of the work sessions with us. And then we're also engaging additional community stakeholders, and we'll talk a little bit about how. Next slide, please. So here's our core team. Our core team is made up of folks from the nonprofit space, also from our local government. We have experts from universities as well. This core team, again, has been in place doing this work for several years, and then they are now part of the core team that is leading phase 2 of this work. Next slide. And you also see a list of our coalition members. We have a very robust coalition that includes members of healthcare networks. We have community-based folks. We have folks from universities. And so all of these people have been working diligently with us over the past several months as part of work sessions, helping to lead this plan and to develop these action items. Next slide, please. And then us, we are leading the work around keeping the work coordinated, and Vanu is doing an excellent job of pulling together this data and will be taking the lead on writing our action plan. Next slide. So we're going to talk a little bit about our process. Again, we'll get a little bit more in depth about this at our 12 o'clock session, but we will just give you a little overview of what we've been working on in terms of timeline. Next slide. So we have, since January, been holding sessions. We've had several sessions with our team, a kickoff session where we really oriented ourselves to the work, and then we moved into some prioritization and action planning. And then one great element, as we mentioned, it's really trying to engage the community around this work. So in addition to our coalition, we had several community researchers in the community that led some sessions with mothers and asked them, what are some of the issues that are of interest to you? What are some of those pain points that we need to discuss? And we were able to incorporate that, and we saw a lot of synergy between what we were learning from the coalition and what the community members had to say. And then there'll be some opportunities for you all to give some input. And so there is a public action planning survey. So if you go to the Healthy Start website, and we'll share the link in 1 second so that you see that, there's an opportunity for you to take a survey and to weigh in on some of those action areas and priority areas that the coalition and the community members have determined for you to share your ideas around prioritization. There'll also be a public input session. Can you go back 1 second, please? There'll also be a public input session on March 14th. That will be an opportunity to look at the report in a more final form and to give some input specifically on some of those areas. So that will be coming up. We are, as Jada mentioned, moving towards a very tight timeline. And so the action plan is due on March 31st. And then we will be having a local launch event the week of April 11th, which is Black Maternal Health Week. So be on the lookout for more information about that. Next slide, please. So again, ways to get connected to the work, visit healthystartpittsburgh.org. We have an infant health equity page that shares information about the project. There, the phase 1 report is there for you to read. Some additional information and context is there. You're also able to take the survey on that page. So please feel free to take that survey. We would love to have your input. There's a registration link for the March 14th public input session. And then of course, we'll be sharing some more information about Black Maternal Health Week and the release of the action plan during that week as well. Next slide. So to get us into today and tomorrow, we're very excited about the presentations. We have members of the coalition. We also have members of the community who are joining us for these sessions. We'll hear from 2 of our speakers today, and then we'll hear from the other 3 tomorrow. And so at 10 a.m., we will hear from Tayler Clemm, and she will be talking from the topic of Mama Needs a Village. And so we'll hear from her at 10 a.m. today. And then 11 a.m., we'll hear from Cecilia. At noon, you'll hear a little bit from me again about the project. We'll go a little deeper. There'll also be some opportunity for some Q&A. And then you'll hear from our additional speakers tomorrow, starting at 4 p.m. So thank you again for being here. We're excited about this work. We are excited for you to provide input, and we are very adamant to address this very important topic around maternal child health here in this region. So thank you very much. And without further ado, I will turn it over to Tayler for her session.
Greetings, everyone. Welcome and thank you for being present today. I am honored to be here to speak on infant and maternal health. Today, we will honor the past, highlight the present, and envision the future of healthy birthing communities. I am your presenter, Tayler, and welcome to Mama Needs Her Village. Next slide, please. So a little bit more about myself. I'm Tayler again. I was born and raised right here in Pittsburgh. I'm a mother of 3 children who were all born at home. I'm a lifelong student of nature, a community health advocate and Safer Childbirth Cities Advisory Committee member, a breastfeeding peer champion, and I'm currently on my way to becoming a full circle doula through a scholarship that has been offered by Healthy Start. In addition to, my love of herbalism. Next slide, please. It takes a village to raise a child. It's a popular African proverb that holds its truth to this day. It not only takes a village to raise a healthy child, but to birth a child and properly care for the mother and family. If we are to live the African proverb, then we must intensify our efforts to educate the community on the numerous causes of infant mortality, including premature birth, low birth weight, poor nutrition, preconception health, socioeconomic factors, racism, isolated pregnancy, stress, and low breastfeeding. And honestly, I can continue on. But all in all, mamas need their village. We need our village. Next slide. Losing mothers and babies is a tragedy. Everyone should take infant mortality personally. The infant mortality rate is an important marker of the overall health of a society. And let's be honest, this country is dysfunctional, and we should be able to take care of our most valuable citizens, which are our babies and our mothers. And here's a statistic on the left is in 2020, the Department of Health and Human Services determined that a woman dies every 12 hours from pregnancy-related complications in the US. And here's the kicker, the majority are preventable. So maternal death impacts Black women, of course, at twice the rate of many other racial groups. And unfortunately, mortality is just the tip of the iceberg. For every woman who dies, there are more women who just barely survive. And that is the same for infant morbidity. And here on the right, the figure is the blue line represents PA and the red represents the rest of the United States. So as you can see, the Pennsylvania has a higher rate of infant mortality. Next slide. So we don't need another report or documentary to tell us that racism and systemic oppression is making our mothers sick. Black women experience greater exposure to violence, systemic racism, and microaggression. During these experiences, cortisol and other stress hormone levels remain elevated. So this contributes to preterm birth, low birth weight, and infant mortality. Not to mention, if babies are born too small and survive, they run the risk of developing poor brain development, cardiovascular health, and other health-related issues. So in the documentary, When the Bow Breaks, neonatologist Dr. Richard David said, growing up as a Black woman in the United States is not good for childbearing health. And that's based off of the systemic oppression. Next slide, please. The problems are evident, so what about the solutions? We must save our babies to secure our future. We do this by focusing on midwifery models of care, physiological birth, centering pregnancy, community doulas, intentional community education, Black women-led initiatives, family support, and neighborhood birthing villages or centers. Next slide. We must encourage more of the midwifery model of care. Culturally focused woman-led care sees people for who they are, what their lived experiences is, and what that means for bringing a child into this world. It care builds relations from the moment the family conceives. I've had the pleasure to experience what it was like to have a midwife and a doula care for me throughout pregnancy, birth, and after birth. Each appointment with my care team happened at home. It included my family and was at least an hour long. I felt heard, I felt safe, and I felt celebrated. Alternatively, I've also experienced prenatal care at a hospital. I did not feel heard, respected, or safe. I always dreaded my doctor appointments and felt a great deal of stress and confusion when leaving. And I know I'm not alone in these feelings, as I was able to recently speak with 30 women around their maternity care, and the majority of them mentioned these same feelings. Policymakers, providers, and insurers all have good reasons to encourage a shift toward midwifery. The result would be more choices and better outcomes for mothers and babies. Next slide. Black midwives are crucial in reducing infant mortality and creating good family outcomes in our communities. Traditionally, the midwife served the woman and the entire family. Her midwifery included family healing, traditional practices, spiritual healing using herbs, prayer, and evidence-based birthing practices. The social role of the Black midwife was a pillar of our community. In many cases, she held us together and maintained the traditions that solidified families and built community. The acclaimed midwife, my apologies, midwife Sophia Monroe, who's also a doula trainer, said that one of the darkest moments in U.S. history was the systemic eradication of the African-American midwife from the community, resulting in a legacy of birth injustices that unfortunately we are dealing with today. Next slide, please. In order to understand our present situation, we must look at the past. When Europeans brought African people to the United States and enslaved them in the early 1600s, among them were African women who were trained and practiced as midwives, and who continued to do so and train others to do so during their lives enslaved. During this time in the colonies, midwives were still the primary source of care and birth for all families. As slavery grew, African midwives served both African women as well as white women in birth. In the mid to late 1700s, obstetrics was introduced into America, and middle-class white Americans, in America, and by the early 1800s, the male physician had largely replaced the role of the midwife, particularly among upper and middle-class white Americans. However, in rural America, and particularly in Black communities, midwives continue to serve in birth. I wanted to mention as well is that midwives, in our culture, we did not have a term for midwives. We were spiritual healers. We were community healers. We were mothers. We were aunties. We were grandmothers. We were women who were knowledgeable around birth, and we took care of our mothers. So systemic racism decreased the number of Black midwives. So as you can see, in Mississippi alone, there were more than 5,000 Black midwives in 1920. And in 1985, there was only one practicing midwife. This became the norm throughout the southern states, and in some states outside the southern region, there were no Black midwives at all. Next slide. So midwives are the original and the most common birth attendant in the world for all women, even today. They are the first professionals. Here are just a few things that midwives and now most doulas do today. They provide quality prenatal and postpartum care. They provide education and resources. They support the laboring mother with techniques to get through their labor. They offer herbal remedies, which is a big taboo today, but our people always use herbal remedies. And in fact, when birth started to become regulated, when midwives started to become regulated, they had to hide in their birth bags their herbal remedies and things because it was no longer allowed in birth. We also pass down knowledge to other women. We educate. We incorporate our spirituality in our practices. Midwives and doulas today are doing these things in a holistic way. Next slide. Unfortunately, the standard practice in U.S. medicine supports a disease-based, doctor-centered, patriarchal model of care, as opposed to a patient-based care, which emphasizes collaboration, understanding, and choices. Policies and protocols in hospitals are set up to avoid liability. So this has been embedded in our subconscious for a very long time. What we see on TV, what we experience when we throughout our lives, this patriarchal model of care is dangerous, especially to women of color. This quote here says, "I will make your pains in childbirth very severe. With painful labor, you will give birth to children. Your desire will be for your husband, and he will rule over you." This statement is directly connected, and this was Genesis 3:16 in the Bible. This statement is directly connected to how birth is being treated today. Is looked at as something painful that women cannot bear. And we still are living with this same model of care. Next slide, please. There's a lot of medical research that tells you and your care provider what kind of care will most likely keep your baby safe, baby's birth safe and healthy. But the care pregnant women receive doesn't always match the research. A survey of new moms showed that 90% had continuous electronic fetal monitoring. 87% had restrictions on eating. 66% had restrictions on drinking, and 55% had artificially ruptured membranes, with 35% having episiotomy. Even though they are routine practices, some can actually make childbirth more difficult and less safe. So here on this timeline of interventions, you see how in the mid-1700s, forceps are introduced to help deliver the baby safely during a stalled labor. We now know today that they are harmful and only to be used when really needed. In 1853, they introduced chloroform, which gained popularity after Queen Victoria used the anesthetic during her 8th delivery. By 1900, we see that physicians were attending about half the nation's births, including nearly all births for middle and upper class women. Midwives took care of women who could not afford a doctor. So a lot of African Americans did not go to the doctor because we could not go. We didn't have access to it. We weren't allowed in those institutions, or we just couldn't afford it. And then I want to just briefly mention 1910, when twilight sleep, a treatment involving morphine and scopolamine, made women forget the labor experience altogether. These are all things that were introduced and looked at as good for us to get rid of our birth pain. So it's important to understand the history of interventions in order to know why we're dealing with what we're dealing with today. And let's bring it to 2000, where C-sections accounted for about a third of deliveries. By the early 2000s, over half of all women who gave birth vaginally received an epidural or a spinal block. So these are interventions that oftentimes do not lead to safe and healthy moms and babies. Next slide, please. We are tired of experiencing unfulfilled and traumatic births. We are tired of our babies and mothers not being properly taken care of or nourished. We can change this narrative by keeping childbirth simple, by normalizing practices like letting labor begin on its own, walking and moving around during labor, doulas, avoiding giving birth on your back, and following the body's urge to push, and keeping baby with mother immediately after the birth to establish healthy breastfeeding relationships. It's time to take greater strides to protect our mothers and babies, as most of the leading causes of death are preventable. Next slide. So as we know, Black women are shying away from traditional hospital births and are opting for home births for multiple reasons, including wanting their childbirth to be more of an experience and not just a process. And one thing to note is home birth was the only kind of birth. It is what we did, and it was what was safest for us. However, if you're looking for a Black provider for your care, your options are very slim. The majority of CNMs and CMs, which is certified midwives, identified as 85% white, with midwives who identified as Black or African American being the next common group at 6.8%. So that's 85% compared to 6.8%. Increasing access for midwifery education and doula education amongst Black women is crucial for the health of our village. Next slide. When speaking on infant mortality, we must not forget our fathers. The Black family is being challenged. Our fathers are being hit with higher unemployment rates, racism, homicide, incarceration, hate crimes, and injustices within American society. We must continue to reach out and support the Black father. Having father involvement is part of the equation for preventing the deaths of their babies. In the community, we can address this in our care visits, our childbirth classes, our community workshops, family support groups and counseling, and informally when we're having discussions. Next slide. In the same way that birth culture was altered through colonialism and systemic racism, our food culture has been severely impacted as well. We were people who lived off the land. We were people who grew our own food and used plant medicine for healing and understood the importance of nature. We were robbed of our food culture, which was originally nourishing to our people. The food we eat daily affects how our bodies work, how we heal and grow, and how we maintain energy and strength for years to come. It also determines the basic nutritional health that our children are born with and provides a model for their eating habits during childhood and beyond. Pregnancy and family nutrition is essential to a healthy baby and a healthy mother. Additionally, a fun fact is every Black midwife kept a garden. You know, we kept a garden, we knew how to use our garden, and we knew what plant medicine to use for our community. So everyone should care about nutrition in babies. It determines the health of a nation. Our babies and nutrition are directly connected. Next slide, I see you, thank you. While the persistence of maternal and infant health disparities in the United States may seem disheartening, there are many communities who understand the profound importance of addressing this issue and who are doing pivotal work in this area. The National Perinatal Task Force, or NPTF, is a grassroots movement that wants to start and grow perinatal safe spots in every maternal toxic area, which are areas where it is not safe or conducive to being pregnant or parenting young children. The NPTF is a community of people who have a heart for women and babies and are concerned about the persistent and worsening maternal child health outcomes in the USA. So when going to the Perinatal Safe Spot website, it was cool to see that 3 out of the 7 perinatal safe spots in Allegheny County were Maya organization, which is one of my favorite, the Birthing Hut, which is a beautiful organization around childbirth and doula and doula trainings as well, and Genesis Birth Services. So these are all 3 safe spaces that are in our county that we could be utilizing more to ensure that we have perinatal safe spots and for our moms and babies. Next slide. So what if villages exist already? We don't need any data to say that Black women take care of Black women best. There are many transformational people doing the work to reclaim healthy birthing communities. The following are 8 examples locally and nationally of women taking care of women. So first, the Pittsburgh Black Breastfeeding Circle you see at the top. The mission of the PBBC is to protect, promote, and support breastfeeding as the cultural norm and optimal feeding methods for mothers and babies of African descent in Pittsburgh and surrounding areas. When I was first pregnant with my 4-month-old, I was 4 months pregnant with my first child, I found the Pittsburgh Black Breastfeeding Circle and it changed my life. I was so happy to find that support. The second one you see is Elephant Song Doula Services, which is dedicated to providing birthing people and their families with intentional, selected Black birth doulas, postpartum doulas, lactation professionals, and other complementary maternal health specialists who work within evidence-based standards of practices. They recently opened a working space for birth workers right here in Pittsburgh, Ms. Kia Edwell. Another local organization is Maya, which I also benefited from during my second pregnancy. At Maya, they envision a world in which all parents receive quality care, education, and support throughout the perinatal period. In the US and Allegheny County, birth outcomes are not equal for all. They offer classes, community, and support to improve birth outcomes for Black, Indigenous people of color, parents, and babies. So Maya is a beautiful organization that we can support and fund to continue to do the work. In addition, Nurture Her app, which you'll hear a little bit more about tomorrow, is a mobile app for postpartum mothers to hand select their personal mommy concierge, along with educational mommy tutorials to strengthen and guide along their motherhood journey. Another beautiful piece of work that's being done right in our county that our moms could really benefit from. Masters of Maternity, is a PA-based doula directory that helps clients gain equal access to quality care. And it was founded by 2 Black women right here in the Pittsburgh area. Another great thing that we need in our community, a directory to where we can be able to find doulas to help us with childbirth. Next is Healthy Start in the Center of Urban Breastfeeding, whose goal is to make sure all families have access to affordable quality care to improve maternal and child health outcomes and quality of life. I cannot stress how important Healthy Start has been in my life, especially recently. But this type of work that they're doing, with all the programs, with all the support, the postpartum care, the opportunities, it's really amazing what the work Healthy Start is doing. This town hall, so stuff like this we can amplify and continue. And lastly, I wanted to just share 2 national things that are happening already done by Black women. So Shafia Monroe Consulting, which is a doula training, which I am excited to be in the process of, was built on the legacy of the 20th century American midwife. Their model is unique in that it builds community, it promotes breastfeeding, provides lead poisoning prevention education, creates culturally competency, and promotes civic engagement and policy to generate systemic outcomes to improve the African American communities and beyond. They are doing pivotal work to really address the issues that be and bring back the original ways of, our village. The last thing I wanted to mention is Earth App. I really am proud to see this come to be. The Earth App helps Black and brown women and birthing people have a more safe and empowered pregnancy and parenting experience by allowing you to see how parents of color, just like you, experience care at a doctor or hospital. So it's a Yelp-like app that you can submit your review on, whether it be positive or negative, and that allows other people in our community to see if that's a safe space, to see if we should be going there. And it also collects that data to share with to drive policy and to make changes within the care model that exists today. So Earth App is also created by a Black woman. So again, as you can see, we don't need any data to say that Black women take care of Black women best. We are doing the work. Next slide, please. Okay, so normalizing a community birth village. So Black women-led community-based organizations, or simply our village, are essential to the healing of the Black womb, the Black family, our babies, and the community. One national example is Jamal Birth Village, which is a midwifery clinic in Missouri. In the past year, Jamal families have experienced 97% vaginal births, 99% full-term births, 100% breastfeeding at discharge, and 0% maternal or infant mortality. They are doing the work to change the narrative of birth. Jamal Birth Village also created the Perinatal Wealth Initiative, which aims to provide free training, education, and perinatal wealth resources to 700 community members across the region to support them in assisting their community members with pregnancy and the tools and resources that they need to make healthy, informed choices. Work like this is what is needed. We need to normalize community birthing villages where we can go to in each community, in each neighborhood, so that we can really transform our outcomes. Another birth village that has been created has been Common Sense Childbirth, which is a midwifery school created by a Black midwife named Jenny Joseph in the Florida area. Trainings like this is what should be introduced at a very young age to our people. Next slide, please. So how do we bridge the gap between our families and high quality care and resources? We inform moms and parents about appointments. We create resource kits distributed to all pregnant people. So all pregnant people and families should, when they first go to their prenatal appointment, should be provided with a resource kit or a resource booklet that has all types of resources for breastfeeding, for community support, for physical activity, for educational classes around birth, for father support. There should be one booklet or page that has a resource distributed to every single pregnant person that doctors come in contact with. We also need to include more frequent community education, more resource fairs around birth, more workshops and virtual classes. And we must include the youth in that. Our youth need to know how to give birth, how to support birthing people, how to navigate birthing systems. Another thing that we can do is support the podcast, the media and social media around birth. You know, our media is really tainted in that we still see on TV that birth is a painful experience where we give birth on back and we're screaming to the tops of our lungs. We can increase the positive podcasts that we listen to, the positive media, the positive social media, which we have seen in the recent years around birth. We can also highlight portals like Master of Maternity, where we can get connected with doulas. Next slide, please. So let's all imagine a community where birth happens naturally and with no trauma involved. Let's imagine birth being a sacred family event that is celebrated throughout the community. Let's imagine as soon as a mom knows that she is pregnant, she has a safe space to go to receive support, guidance, and resources. Let's imagine that each community has a birthing center or birthing village where you can receive midwifery and doula care, perinatal health, mental health support, breastfeeding education, holistic therapies, childbirth education, family support services, and so much more. It's time we healed. Our generation depends on it. Our future generation depends on it. So here's my call to action to you. What we can do is host a doula walk and talk. So what is a doula walk and talk? It's simply going on a walk with a friend, a sister, a neighbor, anyone, a child, and talking about what a doula is. We must start talking about these things that are saving our lives. We must talk about the women who are connected to resources and can help us have better birth outcomes. We must start talking about it. So I challenge you to every person, or to once a week, once a day, tell someone what a doula is. We can also buy a home birth child book. So I have a few in my home, and they're really helpful in educating little ones on healthy birth practices like home birth, like breastfeeding. It's important that we focus on our youth when changing the narrative, because they are our future midwives. They are our future doulas. They are our future birthing families. And this book alone, her 12-year-old daughter, yesterday I found out, just created a book titled I Want to Be a Midwife when Growing Up. So, these are books that we can include in our community and introduce to our children. And lastly, we can donate. I challenge you to donate or volunteer your time with Black women-led organizations and become more informed with what Black women-led organizations do exist in your area, and see how you can be involved, how you could become a doula yourself, or how you can educate a friend, a sister, a mom about these Black women-led birthing organizations. Next slide, please. So with that being said, I would love to take questions or answers, or questions or comments around creating a village, a community birthing village.
Thank you, Tayler. So I've been monitoring the chat and reminding folks to feel free to put questions in the Facebook chat comments. But in the meantime, I'll start with some questions and we'll continue to monitor to see what we get. So one question that I have for you is, how do we go about raising awareness of these resources? So you had a beautiful slide where you shared all of these different organizations. And I feel like, especially in Pittsburgh, but probably in a lot of places, we run into what I kind of call the hidden gem syndrome, where there are all these great things, but only a handful of folks know about them. And then you find out, you're like, wow, this is absolutely the resource that I could have used, but for whatever reason, I had no idea about it. So what do you think needs to be done to increase awareness about all of these resources that exist for women around birthing, women and birthing people around birthing?
Yes, thank you, Elise, for that question. So when I first became, when my first child, I first became pregnant, and my intuition just told me, become informed. So the first thing I did was went to the library, took out a bunch of books. I looked online and found all types of organizations like the Breastfeeding Circle, like Maya and Genesis, and a ton of others. And honestly, it wasn't the easiest. I had to search, and there was not one database or one place I can go to find all these things. I had to do it on my own, and most people aren't doing that. They don't know about these free classes that you and your partner could take to help with birth and postpartum, and understanding how to navigate your birthing experience. So and even in doing this work, I had to look into these programs. And honestly, the only reason why I know is because I'm a community health advocate, and I submerged myself. So one of the things that we can do is really be intentional. So when our mothers are going into traditionally they go into the hospital for prenatal care, the doctor or the care provider should have a resource list. So in my doula training as a full circle doula, we are required to create a resource list for all of our mothers. That should be a requirement for anybody who's providing care for a pregnant mother and their families. They should have a go-to list, book, something that has many resources for all types of the childbearing experience, breastfeeding, postpartum, everything in one space. That should be a requirement, because most times in our doctor's visits, they don't tell you about these things. They don't even tell you about Healthy Start, which is kind of like, absurd to me, because that should be especially in Pittsburgh, every mom should know about these resources. And another thing is just having campaigns, having resource fairs, where everyone is involved, and making them annual things to where we get people coming every year. We should have Pittsburgh Black Breastfeeding at the table. We should have Elephant Song Doula and Maya and Nurture Her app and Healthy Start and Masters of Maternity. We should have, and Earth app. We should have all of these places all the time in one space. So the resource fair, the doctors, and media, again, media is big. Our kids and our people are watching TV a lot. How can we put this on the TV? How can we change the narrative? How can we locally just, even on the news, let's get, a weekly news post saying, when you're pregnant, you go here, you do this. We really have to be intentional about changing the narrative of our moms and babies. It's not really that hard. We make it hard by, all these reports and things, but you see we're doing it. We just gotta, do it more. And honestly, in my opinion, we gotta do it ourselves. We gotta create those birthing village. Every corner in every neighborhood should have a space where a mom should go. She could walk inside. She could feel safe. She could talk to someone. She could feel heard. I'm rambling on this question, but a lot of moms that I recently talked to mentioned how when they go into a doctor's appointment, the receptionist, ignores them or is not friendly or welcoming. No mother should have to experience that, especially when they go to a space where they should feel safe and they should feel cared for. So we really need those birthing villages or birthing centers in every community, not just, one midwifery center in Pittsburgh. It's not enough. It needs to be Black women led, and it needs to be in every community.
Thank you, Tayler. And that's actually a great segue into the next question, because somebody wanted to for you to expand on your idea of villages. So the question is, who or what combination of organizations in Allegheny County do you think are best equipped to create a birthing village like the one you described?
Ooh, that is a wonderful question. So I believe Elephant Song with Kia Edwell. She and I don't know too much, and I haven't had the chance to meet her yet, but I know that she created or she's involved in creating a birthing space, like a workspace for birthing moms to go to. So I haven't been there to visit, but that's a physical space. Also, I know that Ayana, Doula Ayana, she is the creator of the Birthing Hut. The Birthing Hut is, she trains doulas. She's on tons of beautiful work to lead this, to change the narrative. So she would be a beautiful person to lead, to create a space. There's so many of us that could just come together and start, the first village. But it's important that it's not just, we don't need just one, because there's so many of us. We can do multiple, and we should do multiple, at least on each side of, the city. But, Kia Edwell really has her feet in the door. Ayana with the birthing hut really has her feet in the door. Maya organization is an organization who, you could take classes, therapy, support, they're big on support. They have a physical space already. There's lots of women doing the work, and I know that I'm missing some. There's lots of women doing the work. It's just really, let's create an advisory committee with all of us to get together and figure out, okay, where are we going to start this first? What makes sense? Who has the most feet in the door in order to get a space? And let's look at the models that are going on nationally. How did they start? Where did they get space? The people who I mentioned earlier in Missouri, they had like 1 acre of land where they created their first space, and now they're looking to build on that same land another building for a birthing retreat type space. It's really just, where can we find land, and we really need the resources. We need people to support us doing the work, not just giving, someone else to do. We need to do it, and we need to be provided those resources to do it. Because this work is so important. We must care for our babies and our moms. It's really important. So those are some folks that I could think of.
Thank you. Another question. So this one says, I would like to know if you have any advice on someone who has had multiple C-sections but has no medical reasons for them besides previously having one. Is it too late for that individual to retry a vaginal birth? Are there places that are free or covered by state insurance or low cost for a woman with that issue?
That is a beautiful question. It's very unfortunate because, if you ask that question to your care provider, for the most part, they would say no. There is no option for you, and you must give a C-section. And it's just not the truth. It's not the truth. There are women all around this world, who give birth, what is called VBAC, which is vaginal birth after cesarean, all the time. But what it takes is being informed. And our care providers have to become more informed on that part too. But the thing about C-sections is that it costs. So, every time someone gets a C-section, that hospital and that doctor gets paid. So that's what is, unfortunately, I have to say, it's what's preferred. And that's why we go towards it so fast. We don't want to have to wait hours in labor with the birthing mom, So when we have a midwifery model of care, when we incorporate the doula who's informed on options like VBAC, when we normalize these models, we can be supported in those decisions, because all moms can, should be able to access physiological birth, which is just birthing on your own terms. And your C-section does not prevent that. I know moms or read stories that had multiple births after multiple cesarean sections. It's just about becoming informed. When I first started to read up on birth, there's many books that you can read. There's many resources online. You got to create your own communities, what I've noticed of like-minded individuals. But one thing that we need to do is inform our care providers need to be trained on other ways. It can't just be on us. We have to inform the care providers on other ways to birth naturally. And most of the times we get C-sections. Well, I'm not going to generalize that. What I am going to say is that the interventions that I mentioned earlier in the presentation, a lot of them are directly connected to the C-sections. So when we are not feeling comfortable in our birthing space, we don't trust the people. There's all these lights, there's these noises, there's random people coming in and out. Our bodies literally stop doing what it's doing. We're not able to give birth. It's the flight or flight hormone where our bodies, tense up. It doesn't allow us to really birth. We're laying on our back. These things don't allow for a natural birth, and it makes it harder. It makes it more painful. We're being induced. You have moms who, it baffles me when moms say that they're giving birth on this certain day, but I always have to remind myself that that's the scheduled C-section. But for the most part, all women, 99% of births should, be pain-free, or not. Pregnancies should be, or you should be safe to give birth naturally. We just need to be supported. We need to feel safe. We need to feel safe. In hospital settings, for the most part, we don't feel safe. We're hooked up to IVs. We can't move, which is natural in birth. We are movers. We are always moving as a people. So we really just got to change the entire narrative. There's so many factors in it, but the first thing, as far as your particular situation, become informed. Surround yourself with people like myself or others who are knowledgeable on VBACs.
Thank you. And just to follow up, so what are some of those things that you could say? So absolutely getting connected to advocates like yourself and having them be a part of the process. But if a birthing person is in a situation with their healthcare provider, what are some things that they could say to their healthcare provider to advocate for themselves?
So one thing that a mother can, and sometimes, well, me personally, whenever I was in the doctor's office, I lost my words. I couldn't talk. I was sweaty. I was intimidated almost. I just felt like I couldn't defend myself. And so that's why a doula is so beautiful, because they are trained to be confident. They are trained to be knowledgeable. They are trained to be your education, your support on these issues. So if you are in a situation where you're with your care provider and you want to inform them that I have. So you always want to come research-based, because that's what they want. That's what they need. They need those statistics. They need those numbers. So you can, I like to go to evidencebasedbirth.org or .com, evidence-based birth. But you can even look up on that website, VBACs. But becoming informed, saying that it is research-based, that VBACs are possible, and we can do these routes versus, scheduling a cesarean. Or you could say, I would like to, let me say something really fast. Birth plan. Birth plan is crucial, because in your birth plan, that's where you could put, I plan to give a VBAC. You could say, I plan to do this in labor. I plan to use a birth ball. I plan to use a shower or a pool to help with labor pain versus these things. I plan to not be induced. In the birth plan, you can create all these things, and your doula will help you with that. And birth plans are only needed because we're in the hospital. We didn't use birth plans before, but because we are in the birth hospital environments for birth plans should be crucial, or every woman and family should create a birth plan that envision, it's just really, a birth plan is just, what do you envision in your birth? First, just close your eyes and say, what do I want my birth experience to be? And when you're able to envision that, then you can write down some of the things, and you share it with your care provider. And there's many other ways many information online about the birth plan, but I highly recommend doing that to help inform yourself and to help, gain that confidence to share that information with your care provider. And like I said, they want evidence-based, so give them some statistics.
Thank you. I think those are definitely great tips. It definitely can be an intimidating place for a birthing person to walk in and be with a healthcare provider and feel like they lose their words. One thing I also like to do is I like to ask my healthcare provider, well, you share some research with me. I'd love to know, what your basis is as it relates to the decision that you want to make on behalf of me. And, that's been helpful in pointing me towards some resources to then do some of my own research as well. So I'm looking in the chat. I do see some comments that I just want to lift up, because I think that there are some important things that have been shared. And so, just folks who are sharing about wishing that, these resources that you shared were available because of very traumatic experiences during birth. I almost died after having my son in 2012. I could have used a support resource that involved women like me. There's also a comment about breastfeeding, and I'd love for you to talk a little bit about just breastfeeding and how we continue to normalize that. The comment said, I breastfed my son, but I didn't have any women in my family who I knew that breastfed. I wonder if it was because of the past trauma of wet nurses. So maybe we can talk a little bit about just how do we continue to normalize breastfeeding. I know that when I went to a birthing class, when I was pregnant with my first daughter, they talked about how, because of capitalism and formula really being pushed, a lot of women were given medicine that dried up their breast in order to promote formula. So what are some things that we can do to continue to advocate and push the conversation and narrative around normalizing breastfeeding?
Yes, beautiful questions and comments. Yeah, and so breastfeeding is so important. I'm gonna say it like 2 more times. Breastfeeding is so important. And 1 more time. Breastfeeding is so important. And I say that because, it really transforms, and, there's statistics that say that it reduces breast cancer. It creates that bond between a mom and baby. It's so important. And the fact that they make it like a second thing in the hospital needs to be changed. Every mother should be immediately introduced with a lactation consultant when the baby is born. Every mother, and I spoke to a woman recently who said the lactation consultant helped, but she instead of like helping on how to give the latch, she mostly said, if that doesn't work, then she pushed formula a lot. So we need to have lactation consultants that are culturally aware, and also who just are really dedicated to creating that healthy breastfeeding relationship between mother and baby. And also, funding Pittsburgh Black Breastfeeding Circle and other circles like that, so that they continue to do their work and continue to be seen, and continue to have meetings. Those monthly meetings that we had were just so beautiful in my first introduction to birth, my first, with my first child. So we really need to make sure that moms are immediately, if there's a mom in a hospital who's giving birth, she should immediately be given like a tote bag or something with Pittsburgh Black Breastfeeding material in it, or like a lactation consultant. But I really enjoy Pittsburgh Black Breastfeeding Circle. But we really just need to push it more in hospitals, especially with our premature babies. There's many statistics that show that breast milk is what they need. They need to be immediately after birth too. Our babies need to be put on our mom's chest. Most tests and cleansing of the baby or whatever can be done right on mom's chest. That helps build that breastfeeding relationship immediately. And of course, if the mom is okay and the baby's okay, that's what happened. The chest is the best space. It keeps the baby warm. Most times we put the baby in an incubator to be warm, but the mother is the warmest space most times. And if they can't establish that skin to skin right away because any medical condition, they should be put on the father or, on a partner. We should be creating that skin to skin relationship with the baby immediately. So really being more intentional about spreading the benefits of breastfeeding. That should be done in the prenatal appointments. We should be having breastfeeding education through youth in our schools. They should know about that. My little niece when she comes over, she just sits there and stares at me nursing my child. And it's, that's what we need. We need to normalize that. They need to see that from a very young age, that this is normal and this is the best way for us to feed our children. And honestly, let's keep it real. Breastfeeding is not for everybody, but the formula nowadays is not healthy. The first ingredient in most of them is sugar. So if we're going to promote formula, we need to create a healthier formula. I think that's kind of beside the point. But breastfeeding is so important. So I think that those solutions will be helpful.
And again, let me just circle back and ask. So you talked about the breastfeeding circle and the monthly meetings. What can folks expect at those meetings when they attend?
Great question. So you can expect food, you can expect childcare, you can expect moms and fathers, you can expect education, support, laughter. You know, I mean, it's such a beautiful environment. And we, of course, we haven't done them in like I don't know, like a year or two because of the pandemic. They did switch virtual. But that in-person meeting, it just changes the game. Like, you know, it was so beautiful. You know, Ngazi, who's is the leader, she would just, you know, she bring her black baby doll, and teach us different ways and carrying the baby. Different people would come and teach us about yoga, or teach us about wrapping the baby, which is so important for moms too. We should, all learn how to wrap the baby in some type of wrap or cloth. But the breastfeeding circle is more than the breastfeeding circle. It's just it's a great space. So that's what they can expect. And they also have a Facebook group, Pittsburgh Black Breastfeeding Circle. So you could ask your questions, you could come, and that's what the in-person meetings are like too. You come and ask your questions, you come and learn some more, you come and commune, you come and be within your village.
Thank you. And I see a comment in the chat talking about just not feeling supported in that space around breastfeeding, and just been given a pump and kind of told to go on your own. And so these definitely seem like great ways to support moms and birthing people as they get prepared for breastfeeding. So any final thoughts or things that you want to share before we wrap your session, Tayler?
Yeah. Thank you. I just really encourage all women and all mamas to get back to natural physiological birth. Let's stop, let's focus on nutrition throughout our health. Let's focus on creating a healthy support system for pregnancy, and especially our postpartum periods. Let's really get back to the midwifery care, our ancestors who always took care of us well. So let's just get back to that. We know how to do these things, and let's do it well. And let's take control of our health. We must take control of our health. So thank you so much for having me. I love talking about birth. I love all things birth. So I'm grateful to be here today. And I look forward to listening to all the other beautiful presentations.
Thank you, Tayler. So at this time, we're going to get ready for our next presentation. It will start at 11, so stick with us, and we'll be back in a few minutes to start. Welcome back. We're getting ready to move into our next session for the morning. And so in keeping with this idea around connecting mothers and birthing people to resources, our next session is called Help, Stigma, and Underutilized Support Resources for Families. And we'll be hearing from Cecilia Essex this morning, who is a community resource navigator. Thank you, Cecilia, for being here.
And thank you for allowing me this opportunity. First, I would like to just introduce myself. I am a mother of 5 children who recently relocated back to the Pittsburgh area. And being here for the past few years, I've realized having 2 babies here in Pittsburgh was much different than the care that I received in other places. And I thought I would like to point that out. I actually started a nonprofit organization dedicated to fixing some of the gaps here in the Pittsburgh area that I have seen, so that families don't have to feel alone with what they're going through. So if we could just pull up the slides. That actually is not the right slides. I don't know if there's something that I can do. It's been updated since then and another slide was sent out. I apologize. Let me see here. Okay. All right. So we can go off of this slide that's on here. I could go with that, I guess, if that's possible. I don't, I'm on my phone, but I just resent it. I don't know if that went through. But basically, 2022 brings about so many interesting views that it's hard to know what's really going on. So I put together a presentation that looks into what I feel are some of the factors in both the medical and mental health field that contributes to the racial disparities and also the care and upbringing of infants in the BIPOC communities. For those who aren't familiar with the term BIPOC, is the Black, Indigenous, and other persons of color. So I'll be referencing that a lot in my presentation. Here in Allegheny County, we have 27 family centers. And those family centers are a great place to go and receive some assistance when facing any struggles. I have been able to experience those firsthand. However, when it comes to the family centers, the lack of participation from the families they serve makes that difficult. How can someone take advantages of a program that they know nothing about? And in turn, how can an organization provide programming when they aren't sure what else would benefit the families that they're trying to serve due to the lack of participation? Yes. I'm not seeing anything. I only see a picture. I apologize. Yes. Oh, wait, let me see. I'm just navigating between both screens here. And no, that is not mine. Oh, let me see here. It's still the same blue screen. It's just formatted a little differently because I've added a lot of pictures into the presentation. And I just reshared it with Alan. And that's okay, because I reshared it with the Alan at Cut and Run. That's correct, right? Okay. Okay. Well, I can go ahead and am I still being heard? Okay. And so I'm sorry. So basically, I was just mentioning how many of the programs aren't being used to their fullest capability. And this in turn does not allow either the center or the family to be able to reach their potential. So then when you think of other factors, like the fear of social services coming to remove your children, and not being able to understand or know why, or the repeat cycle of untreated mental health in your family and in your community, it really shouldn't be hard to see how infant inequality based on race is still a problem in 2022. So on my second slide, when it comes through, I have a picture of me. Well, I have a picture of my child, who actually, this is child number 4, who was born due to a C-section, that I never, like to this day, I don't understand why I was forced to have that C-section. Kind of goes back to what Tayler was talking about, other than the fact that my third pregnancy, which was it was about 5 years prior to having this child, the only answer I could get is because you've already had one. But the research that I had found on my own showed that I really didn't need to. But when I kept questioning having to have the C-section, I was told that if I didn't want to have a C-section and I wanted to get a VBAC, is what it's called, to be able to give a vaginal birth after a C-section, then I would have to find a midwife, and there was no midwife center. The midwife center and all the things that I was able to find at that time did not have anything I could afford or that would accept my Medicaid insurance, which is where the family centers actually gave me a lot of help. However, I didn't learn about those here in Allegheny County until after that child was already born. So once those slides are up, I can show that picture. I stated how Black women are 3 times more likely to die in childbirth when compared to white women. And 60% of those deaths that occur are preventable. The need to support our working mothers, both while pregnant, after pregnancy, and into childhood, as well as affordable and quality childcare and maternal mental health stability, are all maternal health factors that add to the inequality on the infants, the Black and brown infants here in our country, and honestly in Allegheny County. The United States, I'm sorry, what was that? Yes, this is it. So if we can go to the next slide, please. Okay, great. So the United States has the highest, so like I mentioned, that's Joshua. That is my 4th child that was born. And that was our initial bonding moment. I'm on the other side of the table with this screen, and I wasn't even able to, feel or hold him for a few seconds. After my vaginal births, you're immediately having the baby. They actually took my child and, did their whole thing and then gave him back to me. I guess that's sometimes typical. With my 5th C-section, it was a little different because I was able to give a better birthing plan. But there's many people who have C-sections and don't even know the importance of those initial moments in bonding with your child. But yes, so over the past 25 years, the rate of maternal deaths in the United States versus the developed world has actually doubled. What works for some pregnant women's lifestyles may not work for another, which causes deficiencies in other prenatal health concerns. Having 5 children in 2 different areas of the country has caused me to notice some differences in the way healthcare is given. And I now believe that has a lot to do with race and the understanding that not all bodies are the same. My blood type isn't a typical one, mainly because I have a weak D antibody. When I donate my blood, I'm considered O positive. Because of this, they, don't want my blood to be rejected for people with negative blood types. So that's why they have me as O positive. But when it comes to me being a patient, I'm O negative, because if I were to ever need a blood transfusion, then they would have to give me negative blood type so that I wouldn't reject it. So something that is very complicated, it took me a very long time to understand, and no doctors could explain that to me. And for the longest, because I do donate blood, and I've known that my blood type has changed from negative to positive. So for the longest, medical doctors made it seem like I was crazy and that this was a mystery that took me a while to figure out, because I was told that it was not possible. But I did learn after a long time that what the reason was. Next slide, please. So one thing that I still cannot fully understand include things like like why I have to receive this shot whenever I come to Pittsburgh. But in Boston, where I had 3 of my children who all have positive blood types, which is the purpose for this shot, they never even mentioned it to me. And also in Pittsburgh, I've actually suffered from 2 miscarriages that they've told me have nothing to do with this vaccine that they're giving me. But in my opinion, I feel like that's a huge factor in what's going on with my health and prenatal care. When I brought this to my OBGYN's attention, no actual responses could be given to me. But yet at Boston Medical Center, was where I delivered in Massachusetts, everything that I was questioning, I was able to receive advice from. I actually had a Black male Haitian doctor who delivered my first 3 children and never had any concerns about anything with any of my pregnancies. That once I became a resident and had to come to Allegheny County, both UPMC and AHN facilities had a lot of things that I was just so unfamiliar with, and medications and just different things that I had no idea why they were trying to give. I actually ended up having to reach out to Boston to find out about my blood type, to be able to better choose in getting that shot that they had me come and get. So if we could have the next slide, please. Let's see. Here I have women in the workforce, because I am a working mom, and a lot of the issues I have experienced includes being able to work and breastfeed, and the type of insurance, that you have when trying to do things. There is a lack of proper breastfeeding accessibility while at work. There's a lack of conveniently located childcare centers, and a lack of the baby being accessible to a mom during working hours because of short breaks and other things. Sorry, I'm losing my spot here. While I was in Massachusetts, I was able to have a midwife and a doctor at the same time, with no issues from my insurance company. Mind you, I did have a regular out-of-pocket employer-based insurance with Medicaid as my secondary. Here, Medicaid has been my primary. So I never really wanted to focus on that and believe that was an issue in the care that I received. However, these facts are kind of making it impossible for me to deny that. I already mentioned having to have C-sections. So with my 3rd child, I had a birthing plan. My doctors and the team and the midwife and everybody that was surrounded beside me knew I did not want to have a C-section. And when I was 37 weeks, so I was around 37, 38 weeks pregnant, I found out that my baby girl was breech, which means that the baby is upside down, and they wanted me to have a C-section. So with my adamant not wanting to have a C-section, I found out that there's something called aversion, which is where they turn the baby in your stomach. I was told it was going to be uncomfortable. They don't do it with any type of medication or anything. And in a sense, it was slightly painful, but it was successful. And actually, ironically enough, a risk of that version is ending in an emergency C-section. So I had a version performed, everything went fine. A few weeks later, I went into labor. While going into labor, as I was trying to push to have my child, to push my child out, her heart rate was dropping. And so it ended up being an emergency C-section. And once we got her out, we realized that the umbilical cord was tied around her neck, which is why when I was pushing, she was losing air from being kind of strangled. So I was extremely thankful that we were able to have this ended in the emergency C-section after trying everything that I had wanted to not have the C-section. And I was very thankful for the care that I was given. Now, to this day, I can still remember the care. I remember the doctor saying, "This is Essex. I know how bad you do not want to have this C-section. However, we feel as though it's best," and they quickly explained my options and got me ready. Here in Pittsburgh, when it's not even in the sense of an emergency, I personally have been unable to find anyone to be able to give me that same reassurance that my needs are being met and that the feelings of what I would like for me and my child are being met. And then, mind you, this is the same doctor's office that I had in Massachusetts that that after my second delivery, I refused a postpartum, I refused a blood transfusion because of me not understanding why my blood type kept changing and just all of the different things. And they never once felt the need to contact any type of other facility like social services or do anything outside of provide me the care that I need to know what's going on with me and my child, which I have not been able to say the same for the area that I'm in now. In Pittsburgh, it has been really hard for me to find that care. And the only difference I can see besides the geographical location and the makeup of the community that we live in would also be my insurance. So if you could please go to the next slide. Let's see. Okay, and one of the things that I have here, I have the breastfeeding babies on the move, because breastfeeding is good for baby and good for mom. And with the push of things like breastfeeding, with the thing of pushing things like C-sections, breastfeeding is automatically given a less of a chance because that initial bond of placing the baby on the chest is delayed due to mom being extremely tired and due to just different situations that occur when you have a full-blown operation versus just pushing out your baby on their own. The lack of proper breastfeeding equipment and accessibility of work, the locations or costs or place of, locations or the cost that places a burden on a mother and her infant. Just a whole bunch of different things are affected. And that caused a thought that was on the previous slide that had occurred while I was at work one day that actually is what caused me to really work hard into developing the No Slack Center. I'm sorry, could you put that slide back up? Yes. So I had a coworker who was rushing back from break at a job that I was working, which was actually one of my first corporate America jobs, that had a very strict routine into when you were able to log in and out and when you were able to take your break. They didn't care if you were breastfeeding. They didn't care if you were, having issues with your children at home. If it was your time to be on those phones, it was a call center. They wanted you to be on those phones. And my coworker had come in and stated that sometimes they wish there was a program that could deliver breastfed babies to be able to have their mom, bring them from their mom at work back to the child care provider when a nanny isn't an option for the family. I apologize. I have a few distractions going on in the background that's getting me a little bit mixed up right now. But that is why I decided to finally being able to dedicate my life to figure out what ways I can help make these obstacles mothers face, especially as mothers of the BIPOC communities, so that we can eliminate these issues that give our babies a more of a rough start from the beginning. So if we could go to the next slide, please. So with current issues, I'll focus on the slide with breastfeeding and working. Like I mentioned before, and like a lot of us are probably familiar, there is a bond that's formed by being able to have your baby on your breast. The typical workday does not allow time every few hours to be able to nurture and nourish that baby with breast milk when you're working directly from the breast. Nannies make a great example for these situations. And then also there's dads who experience a perinatal mental health disorder following the birth of a child. And simple factors like breastfeeding could be issues with that in regards to breastfeeding, which is why there's some people who make other options of bottle feeding so that the baby can still receive milk. There's a lot of things that go on with both mom and dad, whether it be the dad not being able to be taken off of work or whatever the reasons, this is something that affects both mothers and fathers. And I personally feel as though it affects members of the BIPOC community much more than it does of any other race. So with current issues such as formula shortages, formula recalls, babies being born sick, and even dying from store-bought formula, BIPOC mothers have less resources available when trying to obtain breastfeeding-friendly childcare, especially in regards to hiring nannies. An article in the New York Times was actually dated, "Nanny Hunt Can Be a Slap in the Face for Blacks." Although this article is a few years old, I believe it was from 2013, I wanted to point out that many of the facts are still the same. This article started by talking about a Black mother, not a single one, but one with a Black husband who both held college degrees and wanted to work, who went searching for a nanny for weeks and was constantly turned down, mainly because of the location of where they lived, which was located in the suburbs of their city. And shockingly, a huge issue was that nannies, including those who were Black, did not want to work for a Black family. The article talked about how many African American and Caribbean women who are nannies would say things like, "Why didn't you tell me the family is Black?" or go on to mention accusations that included low pay for extra work, fears that employers will look down on them, and stated suspicion that where Black people live was not safe. I personally have a family member who's I'm biracial. My mom is white and my dad is Black, and I have a family member who is of a darker complexion who has made a lot of comments in the past that really got me to notice how stigmas and different prejudices are so embedded into us that we don't even notice when we are partaking in them. Over the past few years, I would like to mention that their opinions have changed, but it's really hard to tell with how things are in 2022, especially in Allegheny County, if that's because these are her true feelings or because she's starting to become more politically correct. And because of the lack, and she's a very hardworking mom who has a lack of support in the workforce and has been, given that choice of having to choose between work and home. She ended up generally somewhere in between, which is what I feel happens to a lot of women. Mothers have to make a decision, and some can call it being forced into the choice of having to scale back their professional aspirations towards a better future, or by putting your baby first, since you need to support the child financially. Things aren't always perceived in everybody else's eyes that things aren't perceived in everyone else's eyes. And sometimes we need to figure out how to do what's best for us without worrying about what everybody else thinks. I believe that this leads to poor mental health and your bonding with your infant. If we could go to the next slide, please. So I decided that I would take a few moments to talk about a stigma and what that is. Stigmas generally involve three elements: the lack of knowledge, negative attitudes, and people behaving in ways that disadvantage the stigmatized person. One of the biggest stigmas in the Black community deals with mental health. And then there are two types of stigmas associated with mental health: self-stigma and social stigma. And I personally feel that people in the Black community have been systematically programmed to experience both. One of the main causes of a stigma is just plain ignorance. And ignorance is not necessarily a bad word. It simply means that someone does not know. One thing people do not realize is that being a Black woman or even a Black man in today's society has most individuals feeling that they must act a certain way instead of being themselves. They must live up to what society views them as, or maybe even more so, what they do not want society to view them as. This causes self-stigma, which is the hardest, especially when it links together with a social stigma that has been around for as long as this country was formed, and that's been over 200 years ago. Breaking these stigmas will not be easy, But in order to help the infants and youth of the current Black community and those babies to be born in the future, we need to figure out how to put them to an end. When I was initially breastfeeding my very first child, who's now 12, my own family and my in-laws' families were the ones making me feel the most uncomfortable. They had wanted me to go ahead and give that baby formula. They wanted me to go ahead and eat things that I wasn't able to eat because I was breastfeeding. And there was even comments made talking about I wasn't in the house anymore, having to feed other people's babies as a living. With being light skinned, I faced a lot of jokes growing up about being light skinned. And that's when I really started learning that these stigmas and these innocent jokes that individuals thought were okay and were so used to doing really have a very much deep-rooted issue that is never addressed. If we could go to the next slide. Self-stigma is simply defined as a mark of shame you put on yourself. I have some pictures here that just show some different things of stigma. And this is the most dangerous form of a stigma and can lead to serious issues like feeling like you're a burden or that your family would be better off without you. Social stigma is defined as the disapproval of or discrimination against an individual or group based on perceivable social characteristics that serve to distinguish them from other members of the society. In the BIPOC community, the main stigma is blatantly the color that you were born, which automatically makes any social stigma that may be shown lead to certain prejudices. That's also something I'm not going to go deep in, but colorism is a huge issue in our community, which also causes these stigmas to continue. Maternal mental health disorders, like postpartum depression, are the #1 complications of childbirth. 1 in 5 women suffer from a maternal mental health issue, and less than 15% of people are receiving treatment. So imagine the number of all those Black mothers walking around day to day without the support and resources they need. Even dads face similar problems, especially those dads in the Black community where so many different stigmas already exist. So now, how are people able to raise an infant and bring a brand new baby into life when they're already suffering with these issues themselves? There is a lot of research that goes to support how infants and children of parents with mental health disorders tend to have more behavioral concerns such as ADHD, which then gives them a stigma from birth, leading into adolescence and even adulthood, when in reality, those medications and those titles really don't even need to be given if the support of a village or of a resource center or whatever around them was utilized properly. If we could go to slide 9. Prejudices can be classified into 3 categories: cognitive prejudice, affective prejudice, and connotative prejudice. A lot of people place prejudices, a lot of people, in my opinion, in the BIPOC community, place prejudices on having to ask for help or having to use something like a center because that means that you're failing or not doing what you need to do on your own. In my opinion, the cognitive prejudice, what people believe is true, like the stereotype, is one of the main types of prejudices the community faces in regards to mental health. They include expectations, which are sometimes false or unreasonably placed on both themselves and their child, like the single mother of 3 children who's working 2 jobs and trying to help her kids in school and life, and expects the 2 and 3-year-old to be able to get themselves dressed in the morning to be able to make the bus so that they can get to their job that's barely affording to pay for their bills. This also includes things like criticism and assumptions. I feel like these are very similar to the self-stigma that the Black mother tends to place on herself, and I've personally been able to experience. These things don't become fair to ourselves or for our children. Affective prejudices involve what people like and dislike. This is more of an emotional aspect of prejudice. There were many times with my first few children that I was uncomfortable breastfeeding in public because I felt like people would judge me. It wasn't until after having a few children that I realized those feelings of mine were not consistent in all environments. There were times when I felt completely comfortable depending on the group of people I was surrounded by. The family centers I found out, at this time I found out through a friend, when I first started coming to the family centers, they began to have a huge part to play in helping me with realizing myself and how I was as a mother. And these effective prejudices, I feel, lead me into the next type of prejudice, which is the connotative prejudice, which refers to how people are inclined to behave. I feel like they go hand in hand. With the previous example about breastfeeding in public, I ended up changing a lot of my behaviors because I would silence my infant instead of feeding him. With my first baby, when I began to get uncomfortable in a situation of breastfeeding and I ran out of pumped milk, instead of putting my baby back on my breast because I knew he was a little bit hungry, I would justify that he had enough milk and I would give him his binky. And at that time, that was really not what's best. And luckily, I never faced any issues from not releasing my milk that I had, and my baby never received any issues from not being able to drink more when they wanted more. And I learned later that was due to my breast milk, because it is a powerful thing to be able to give to your baby. Breast milk actually saved my daughter's life when she was diagnosed with a very severe bacterial infection at 7 days. And by breastfeeding, that's when I became more confident as a breastfeeding woman and a breastfeeding mother, because the hospital where we were at considered my milk gold. And they really was the first time I had really had anybody give me positive feedback on breastfeeding. So that's when I really started to notice how breastfeeding or not being able to breastfeed was a big deal, and that we shouldn't think that just because, the way your life is set up in society, that you shouldn't, you shouldn't want to feel forced to have to do formula. My first few children was definitely supplemented a lot with formula, which in turn ended up making my milk supply dry out a lot quicker. And I didn't even understand why. But now that I'm more knowledgeable, it makes more sense. And so if we could go ahead to the next slide, please. So here I wanted to talk about the resources, which I've been talking about already, that are available in the family centers and other various types of resources, like Tayler had mentioned with the Maya organization. They are great. And Genesis of Pittsburgh, Trying Together is an organization that has a family center in the city, as well as UPMC, who has family care connections all throughout the city that offer things for both the mother and child and family, and also when it comes to health. And that's also why I have had the No Slack Center, where I'm aiming to be able to provide a gap within the BIPOC community and women and the resources available. And then when the resources just aren't available, which sometimes that is the case, is that there just are not things available, then I would like to use my organization to be able to build that bridge to find out how we can make those resources available or best support the individual going through it while we wait for them to become available. So that basically sums up my presentation today. I'm not sure if there's any questions or anything.
Thank you, Cecilia. We definitely appreciate your just vulnerability in sharing your lived experience and just what has happened and how you've navigated across different cities and states and healthcare providers with your family. And as somebody who is 5 weeks off of a C-section, I definitely felt like I had a similar experience to when you had the one where you did feel that it was a decision that was very much informed and that you felt comfortable making. I had to make that decision. It wasn't what I wanted. I did want to have another vaginal birth, but I did have a child who was measuring pretty big, and the decision was, hey, we should go ahead and do a C-section because she is measuring large. And ultimately, I do believe it was the best decision. But I think in any of these decisions that are being made, it's really feeling heard by your healthcare provider, and for them to be able to really sit with you and answer the questions and really try to help to deal with the concerns that you have. And so I am thankful for that, but knowing that that's not the experience that every mother or birthing person has. So thank you for sharing that. Can you talk a little bit more about the No Slack Center? So I heard you say that it's something that you started. I would love to hear a little bit more about that. And if you want to let folks know how they can get connected to it, that would be great.
Sure. So right now, we are doing things kind of the old-fashioned way. We can be reached by phone. Our phone number, I'll go ahead and provide that. It's 412-872-4390. And with my active participation in the family centers, I realized that there's a lot of people who just don't come. They don't show up. There's a lot of activities and resources and things like free diapers and free things. And also, like Tayler had mentioned, with the breastfeeding groups that they have, just a place for mothers and fathers to be able to get a moment to sit down and talk. While the children are in another area being safely supervised and doing educational activities. And without people in the community knowing what the community has to offer, we at the two separate family centers, we had really at both places had developed a parent advisory committee or council, whatever they chose to call it, which is actually initiated and a big thing going on here in Allegheny County, where they're having those family centers have that type of board just to figure out how can we get people to come to the centers. So with that work, I realized that one of the biggest things is getting it out there, and that it was the stigmas and prejudices that was placed on those individuals who go to those family centers. When I first started going through the family centers, it was from a friend who just was going because she knew actually one of the FDS, is a family development specialist worker, who that's how she started going. It was word of mouth. What I ended up learning to realize is that a lot of these individuals are forced to come to the family centers because of maybe an active CYF case or some type of concern through social services with how they were choosing to parent. So that is where I started realizing that these stigmas in the community were placed on people because they thought that by being at these family centers, people were going to assume that they weren't a good parent or that they weren't doing what they had to do. And just while I was digging further, I realized that, one of my biggest reasons for starting the No Slack Center was because of the family centers. And those are something that really just was not heard of in a city like Boston or Providence, to where you kind of pay for everything and you have to figure it out. So the fact that Allegheny County had these resources available and people weren't using them, it was just like mind blowing to me. And then there was even a moment where I realized I was being very judgmental and placing stigmas on myself and others who were utilizing the resource centers, because I was like, well, they are doing really well. The family resource centers don't care about whether you're low income or making, $1 million a year. They provide the resources to everybody. And they realize that everybody goes through things. So that was a huge thing that I wanted to be able to look into and research. And then I realized that there was also things that I was learning that they were able to also participate in just because they could afford to. And so I started seeing that there was a huge gap that still left a certain percentage of people unable to utilize things or even know that things were in place because of where they grew up or how they grew up or just the people that they were surrounded by. So I'm really taking the No Slack Center and dedicating that to build that bridge from the community members. No Slack Center actually is trying to focus on the lower middle income economic level, because those are the ones that we've realized have the least amount of help. They're the ones who are going to work, trying to maintain, but at the same time, not being able to live their life or enjoy their lives. And then one day when they lose a job, COVID has brought up a lot of new perceptions on people. And there's a lot of people who've been working, for their whole lives and their whole child's life. And then they up and one day lose their job and have nowhere to turn to. So that's one of the things that kind of helped me bridge it together. And we're available by phone. We do have a Facebook page. And it's been something that I've been working on for a few years that's actually just officially launching. Where we, like I mentioned, I'm a community resource navigator. I've been doing that in my line of work for the nonprofits I've worked with for a while. So I've been able to learn about a lot of different things in the community. And one of our first steps is just being able to reach out to whatever an individual or family would need. And then if there are no programs available, then we would like to look into how to create those programs, or to at least create a system to where that person doesn't feel alone and in need.
Thank you. So it sounds like, similar to what Tayler was sharing, just about resources being there and folks not knowing about them. So it sounds like at one end, people just don't know what they don't know about the resources that exist. And at the other end, it feels very punitive if people are being forced to come to the family center and then being there. It's hard to accept resources or support from someone who you've kind of been sent in a punitive way. And so really thinking about how to dismantle that stigma around why you're there, and to be able to really take advantage of those resources that exist. So I want to explore a little bit more. You shared this idea about, working mothers and birthing people, and how there could be some type of delivery service to like bring your child for breastfeeding, and then, take them back to whatever their childcare situation is. Talk a little bit more about that. What would it take for something like that to happen? Because I think it's a really cool idea.
So this is really early in the stages, but one of the programs that we are developing actually does include that, to where we would have, in a sense, like a nanny, which is kind of becoming an outdated term, but in reality, there's a lot of people who do utilize nannies just in a non-traditional way. So we would have someone as a nanny, like in a nanny sense, but not really a nanny, who would go to where that child is located. So if you have a family member watching your child, if your child's at a daycare facility, whatever you do currently with your child while you're working, we're in the process of designing a program that would give that mother mother and father, or mother, a car seat to use for that child, just to make it, we're trying to get it standardized and make less confusion. As COVID, you don't want everybody handling your baby. But these nannies, in a sense, would go to pick up your child from the place of where they're at, to be able to bring them to you while at work. It's something that we need to get, we're working with certain employers to be able to pilot this program. And so, in sense, say you have only 2 15-minute breaks. During that 15-minute break, instead of having to worry about pumping, you can actually have your child brought to you to nurse, to keep that bond together, and then brought back to where they're at. And in that meantime, besides taking the baby out of the car seat and taking the baby out of the and into the place, everything would be left to caregiver and mother. That would be for more so younger infants that still go in the car seat that snaps in. So that way things can be stationary, it can be safe. And we are also working into getting employers to have actual dedicated breastfeeding spaces. For the breastfed mothers, one of the biggest things I always do is I relate to my previous experiences, and I've worked in a lot of different fields, some to where I've had the comfort of going to a whole bedroom because I've worked in a home to be able to pump privately whenever I needed to, as long as everything else was being taken care of. And there was another staff to assist so that I wasn't leaving any of my clients unsupervised. However, my milk would have to go into the same refrigerator that my clients were using, which my clients were developmentally facing issues. So there's times where my breast milk has been drunk. There was a time where my breast milk was open. So in my opinion, it was no longer safe because I don't know what had happened to that breast milk to give my baby. So being able to find ways to support an employee to be able to pump and breastfeed their child safely is one of the main initiatives with that. And that's what we're planning on doing with the transportation of kind of delivering baby to mom in the cases where it's feasible. And then just ensuring that the employers who are not open to that have adequate places for the baby to store their milk. For the mother to be able to store their baby's milk, as well as keep it safe after pumped.
Love that. So you talked at length about navigating the conversations and stigma, even with your own family, around your breastfeeding journey. What advice do you have for women, birthing people who are in that process and really trying to continue their breastfeeding journey, but facing a lot of pushback from the people who are the closest to them?
Knowing that as long as you and your baby are both healthy, that having your own choices and having your sticking. So it's when people say that your gut, trust your gut, or the mother's instinct, those are always real. So if you do have family members or friends who are trying to make you feel inadequate in the choice that you make, or make you feel any type of way in the choices that you're making, be active and advocate for yourself by doing research, sticking with the facts, and then trying to find that community and that those people who will support you, because they are out there. And that also doesn't necessarily mean that you have to cut off those who aren't supporting you, because it's okay for everyone to agree to disagree, but always go with your instinct, because you are the one who has brought that baby into the world, and you are the one who at the end of the day knows what's best. I really believe in mama knows what's best as being a very accurate statement.
Absolutely. So as we're getting ready to wrap up your session, would love to give you an opportunity to share final words or thoughts that you have about this topic. And then I will ask you again to share the information about No Slack with folks again, so they know how to get in touch with you.
Okay. So mainly everything that, to wrap up, resources, especially here in Allegheny County, are out there in all different areas. And utilizing the resource center that's closest to you would be a great first step in being able to figure out what is out there. They are generally based for families with children from birth, or pregnant women, and then with children from birth to age 5. However, even after 5, we're still mothers, we're still parents, we still have things that are concerned. And a lot of the family centers, depending on how they're set up, still work with families with older children. And there is something called funding that the state looks into. And when there's no participation, then there's not going to be any more funding. And so if you really do want to be able to put an end to the infant inequality, we really need to get out there and make sure that we're utilizing the things that are available, which is why I have No Slack Center to be able to help people do so. And as I mentioned, we're available on Facebook at No Slack Center. And then we also have our phone where we can be reached at 412-872-4390. And we hope to be in Wilkinsburg in a physical location within the next few months, next few weeks, actually, by April. We plan to have a space in Wilkinsburg where people will be able to meet up to receive resources and to meet in person with issues that they have. But most things are set up virtually now.
Thank you, Cecilia. We appreciate again just the transparency and vulnerability and sharing your lived experience around your birthing and breastfeeding journey, and for really helping us to think about all of the resources that are there, making us aware of those. And we wish you the best of luck with the work that you're doing with the No Slack Center. So at this time, thank you. And at this time, we're going to wrap this session, and we'll be back at 12 o'clock to talk a little bit about the action planning process. So we'll see you in about 10 minutes. Welcome back, everyone. Thank you for continuing to stick with us this morning for our Infant Health Equity Virtual Town Hall. We've had a great day so far. We had an opportunity to hear from Latasha Mays, who provided our keynote this morning, and we've had two amazing sessions talking about infant health equity and ways to get connected to resources and really overcoming that stigma, especially as Black women, as it relates to our birthing and breastfeeding journeys. So at this time, we're going to get into our action planning process. So we talked a little bit about it this morning, so you knew what was happening, but we do want to share a little bit more in depth and tell you ways that you can get involved and contribute to our process. Again, if you have questions or comments, you can feel free to add them to the chat, and this will be an opportunity to address them. So let's go ahead and get into this. So this is just a little bit of a recap. Again, this Infant Health Equity Project is one of 21 Healthy Start projects happening around the country where we've received some supplemental funds to do some work to reduce disparities in the community. We're using that funding to create these local action plans to look at factors that impact infant health mortality. And the goal is to collect data and input from community members. So that includes our core team, also our coalition, and then the community at large. And this process, again, you saw it said phase 2 is the second phase because it is building on some existing work that is already happening here in the county. Next slide. So this is the team that spearheaded the work on phase 1. And this was the group that came together and started this process of really becoming this maternal and child health strategy team. Next slide. And in year 1, when they started the work in 2019, they did a lot of deep equity work. They also did some work around network analysis and really thinking about who is involved in the network or the ecosystem that we call maternal child health. They also started talking and digging in and building a strategic plan and did a baseline capacity assessment to really understand organizational readiness to implement this work. Next slide. Our project structure, again, consists of our core team, our coalition, and then you all as the community at large. Next slide. So our core team is comprised of the members of the Allegheny County Maternal and Child Health Strategy Team, who you saw in the pictures. They were the co-developers and authors of that phase 1 report, and their responsibility is for planning, moving the project along, and weighing in on key decision points. Next slide. And the core team members are here. So a lot of the same folks who have been involved and engaged in the work since the beginning, a combination of folks from the nonprofit sector, also from our local government, and members of university faculty. Next slide. Our coalition has the job of supporting the development of the action plan, and they've been engaged through a series of work sessions. It's actually been more than 4 at this point. There's been a lot of robust conversations that have bled into additional conversations, and they've been very generous with their time to do so. They've completed some pre-readings and pre-work, and they're also asked to do some in-between session work where they're filling out surveys and contributing to a jam board and providing ideas. And then they're also supporting the promotion of these events. And so sharing out about the town hall. Some of our coalition members are participating in our town hall. And then also, of course, the biggest piece of this is once the action plan is completed, to be sharing that out and then also commit to carrying out the work. There are folks who are part of the coalition who are directly involved in and who have the responsibility of carrying out this work. And so that is an important part of this process as well. Next slide. So again, you see our list of coalition members. It is a robust group. It has grown even since we started the process. We've been in meetings. It's like, oh, well, this person should be here. So we've had a couple folks who have joined us even since the beginning. But again, a great group of folks from our healthcare centers. We also have some independent folks as well, birth workers, mental health therapists, community influencers, some great folks who have come together to do this work. Next slide. So I want to talk a little bit about the context of infant health equity nationally and in Allegheny County so that we can situate our action plan into that context. Next slide. So we have some working definitions, and we've sourced them from a couple places. So Healthy People 2020, also the CDC. And so you see our definitions for health equity, health disparity, and social determinants of health. I won't read them to you. You can take a minute to scan them. But in health equity, I think it's important to point out that we are thinking about the historical and contemporary injustices that exist as we're thinking about achieving health equity. In health disparities, I think it's important to point out the intersectionality and thinking about how that perpetuates health disparities. And then also you see listed the Center for Disease Control and Prevention's definition that talks about things that are preventable, of course, directly connected to some of the disparities that we see, especially at those intersections of identity. And then finally, our definition for social determinants of health that is sourced from the CDC. So just wanted to provide that as an anchor for the way in which we're thinking about these important terms, in terms that we hear a lot that have a lot of different meanings and definitions, but these are the ones that we've chosen to work with. Next slide. And then also racism. We know that that's a word that is used quite a bit. There are a lot of ways to think about it, but we've really centered our work in Dr. Kamara Jones's definition of racism, which says a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. And so that is the definition of racism that we are anchoring our work in. Next slide. So just a little bit of a few statistics about just infant mortality rates by race and ethnicity. As you see, there's a disproportionality of Black and Brown folks as it relates to the infant mortality rates. We see that in 2018, almost 21,000 infants died in the United States, and you see those 5 leading causes of death. You also see infant mortality broken down by state, and you see that Pennsylvania ranks pretty high on that list. And this is some 2019 data from the CDC. Next slide. And then the March of Dimes also has some information about Pennsylvania. And you see even in the Pennsylvania data that infant mortality rates for Black people are much higher. So again, a disproportionality that is represented in this Pennsylvania data as well. Next slide. Here is a report from 2018, the Allegheny County birth report. And so some things to point out: Black mothers had the highest proportion of preterm births compared to all other races, and white mothers had the smallest proportion of preterm births. And then you also see that the racial group with the highest percent of LBW and VLBW were Black, which were down from 2017. And you also see down here that infant mortality rates by race in Allegheny County in 2016, that Black people definitely were represented disproportionately in that data as well. And so saying all of this to really point out, you can go to the next slide, that this is the reason why this action plan is really situated in focusing on Black mothers and Black birthing people in this county. And so that's what that says here. Locally, data directs us to focus on outcomes and disparities experienced by Black women and babies because of what our national and statewide and local county-based data demonstrate. Next slide. So what does our process look like? We talked a little bit about our timeline this morning. I do want to go a little bit more in depth about that. And then I want to talk about the priorities that we've landed on and what those look like. So you can go to our next slide. So what you see on our project timeline is that our coalition has been meeting in these configurations and having these sessions for several months now. We've had a kickoff session where we oriented ourselves to the work and started to have conversations about some of the issues. And then over time, we've had some additional sessions where we've done some prioritization of those action areas and really started to think about solutions. In addition to the work that the coalition has been doing, we've also engaged a set of community researchers. And so we asked community folks to bring together other folks in the community and have conversations about these issues, and taken that data and incorporated it into our action plan. So in addition to the solutions and ideas that were being sourced from the coalition, we also had ideas and solutions being sourced directly from the community through our community research process. So right now, we are in the process. So last week we had some crafting sessions, and so we've taken these solutions and really started to craft out details around them. What is the issue? What is some specific language around what is happening? What are some resources that exist to address the issue? And then where do we see examples, both locally and otherwise, around how to address some of those issues? And so that's what we've been working on in our solution crafting sessions. And so in terms of ways for you to get involved, we are opening up our public action planning survey. That's on our website, and we'll share a little bit more information about that shortly, so that you know how you can get connected to the process, and you can also help us to prioritize those action areas, and also to share some additional comments and input around issues that we should be focused on. In terms of the rest of our timeline, the coalition will be meeting for a feedback session where they'll be seeing a more final version of the report. We're moving into that draft form of the report, and they'll be giving some input on that. We will have a public input session, and so that session will be an opportunity for you as the public to see that draft of the report, for you to go directly into the report and to provide input, and for you to provide edits and feedback. And then we'll be working diligently between March 14th and March 31st to get our plan submitted. And then we will launch the action plan the week of April 11th, which is Black Maternal Health Week. And so that'll be an opportunity to share publicly the action plan that we have, and really think about what the future of this work looks like. Next slide. So as I mentioned, with our action plan focus areas, this has really been an opportunity for the coalition and for the public to really weigh in on issues surrounding maternal and child health. And we've taken those issues and listed them. We've prioritized them. We've done surveys about them. We've asked the community about them. And so what's really risen to the top for our coalition are these 4 areas. So maternal and child health workforce, systems of care, social determinants, and coordinating and streamlining maternal and child health activities. And I will speak a little bit more in depth about each of these areas. We'll go to the next slide. So the first area, strengthening maternal and child health workforce. These areas down here that are listed are 4 focus areas within this topic that we've really been discussing as a coalition and gotten a lot of input on. So the first one being providing supports to retain diverse maternal and child health workforce. We know that we struggle with Pittsburgh and this county being among the least diverse in this country. And so that definitely applies to the maternal and child health workforce as well. So how do we retain the diverse talent that comes here? Of course, connected directly to retention is recruitment. And so what do efforts to recruit diverse maternal child health workforce look like? How do we get people to want to come here? We know that can be especially difficult when we know by lived experience, and also through plenty of research that has come out, that Pittsburgh, Allegheny County are among some of the least livable cities for Black women and Black people in this country. And so how do we think about how to implement those efforts to recruit folks? We're also thinking about how to support particular non-physician mental or maternal and child health workforce workers. And so when we talk about the maternal and child health workforce, we want to be clear that we are talking about anybody who is involved in maternal and child health work, not just physicians, not just people who are in healthcare systems, but we're also talking about all of the other folks that are connected to this area, and how do we support them in more meaningful ways and really elevate those professions and the importance that they play in maternal child health. And then finally, in this category, establishing standards and providing training related to bias, diversity, cultural competency for maternal and child health workforce so they can provide more compassionate care. We heard this morning, we know from our lived experiences that there is a disconnect between the way that some of these workforce professionals treat women and birthing people. And so how do we have some standards and really provide that training so that folks can get the care that they need and they do feel comfortable, that we don't have that reaction where you get in front of your healthcare professional and you freeze, or you don't feel like you're being listened to or affirmed when you're sharing issues that you're experiencing. So let's move on to our next one. We'll go to the next slide and talk a little bit about strengthening systems of care. And so in this area, we're really thinking about increasing our connection to and collaboration with community-based care. What does it look like for this to be really a comprehensive system that includes both the medical system, but also the community-based system as well? We also want to invest in and strengthen key sources of community support, especially in low income or Black communities. We know that there are not the same resources available in low income and Black communities that exist in other communities. We know that the community support may look different. And so how do we really ensure that the money and the funding is there? How do we ensure that the capacity is there for the people who need it the most? We also want to establish a stronger care coordination and integration. How do we make sure that that area is strengthened? And then finally, we want to improve maternal child health related policies and policy implementation in ways that reduce inequities. We know that in these systems, there are policies and practices that happen on a regular basis that perpetuate them. And so if these things are embedded in the way of working or in your value system or in your way of doing, then you're going to continue to perpetuate inequity. So we have to really be adamant about examining these systems that really uphold and perpetuate these policies. We can go to the next slide. The next one is around addressing social determinants. So as you saw on that first slide, we want to really think about, what are some of these bigger issues that we want to be thinking about. And so one that really rose to the top was around transforming workplace policies and environments to be supportive of current and future parents. We also heard about that in our sessions this morning. What are some things that can happen in a workplace, in those environments that really help parents to be successful? What do those policies look like around breastfeeding or around leave for birth? How do we impact those things? Improving access to transportation. We've spoke at length about how do we ensure that we have transportation to appointments, transportation to get to work. When we see continued cuts around public transportation in our region, what are we doing to ensure that folks can get to where they need to get to work? How do we ensure that they can get to where they need to get the support that they need for their health or the health of their children? Of course, this third one I think has been on the minds of folks, for this entire pandemic, and of course before that, improving accessibility and affordability of childcare. How do we ensure that folks have access to the childcare that they need? How do we ensure that it's affordable? How do we ensure that it's high quality? And then another social determinant that has come up in our work is around addressing food insecurity. We know that we have a high number of food deserts here in our region. We know that there are a lot of folks who experience food insecurity on a regular basis, which we know is detrimental to maternal and child health. So that's definitely an area of focus as well. And then next slide. To round out our action plan in terms of the 4 areas, that fourth one being around coordinating and streamlining maternal and child health activities. And so one thing that became very apparent in the work, especially in reviewing the phase 1 work, is that the folks who are involved in this work are not only representative of organizations and universities and government entities that are doing this work, they're also part of a lot of committees and coalitions and collaboratives that are focused on maternal and child health as well. And so it begs the question that when you have all of these organizations and you have all of these collaboratives focused on maternal and child health, yet we see some of the same issues continue year after year, generation after generation, what do we need to do to really streamline and coordinate across the board to improve maternal and child health outcomes? So the first one is focused on increasing the effectiveness and efficiency of maternal child health organizations. How do we ensure that these organizations are operating effectively? And then how do we ensure that they're working smarter and not harder as it relates to improving maternal and child health activities? Another big one is around reducing overlap and duplication of collaborative projects and initiatives. It seems like there's a lot of overlap, like there's this committee and that committee, and when you look at what they're tasked to do, a lot of times they seem very similar, in the same way that some of the organizations that pop up seem to have very similar missions as well. So is it really about the need for another organization, or is it about the need to increase awareness about what exists, to build capacity for what exists, so that we don't feel like we have to continue to start new organizations? Perhaps that is the answer, and in some cases it is, but there's a need to really look inward and think about overlap and duplication that exists with current initiatives and projects. We also want to think about equity statements. So how do we look at the equity statements of these organizations? So in phase 1 of the work, the members of the core team did a lot of great work of assessing their own individual capacity for equity and change. They looked at their own organizations, or at least their vantage point in the organization as related to their capacity for equity and change. But how do we take that same type of process and apply it to all of the people in the maternal child health space? If we're really moving toward infant health equity, we have to have some serious conversations about what is the stance on equity for these different maternal child health organizations. And then finally, encouraging local foundations to fund maternal and child health initiatives equitably. One other finding in the first phase report was just the discrepancies or the disproportionality as it relates to funding for maternal child health organizations. We saw other areas like the education and the arts being funded at much higher levels than maternal child health initiatives, and knowing that if we fund and support maternal child health equity or maternal child health initiatives initially, then the need to fund or address some of these issues down the line don't exist, because we're really starting at the root. And so there's a call to really think about how we fund those initiatives equitably. Next slide. So in order to get connected to our work, we want you to visit the website, healthystartpittsburgh.org/infant health equity. These areas of focus are on the survey. They're represented on the survey, and we want to hear from you about just the ways in which you feel like these would be useful things to focus on, the feasibility of being able to implement them, and the benefit that they would have on the community. So there's an opportunity to weigh in on that on the survey. We also want to hear about other ideas that you have. Again, this has been an open and collaborative process, and every time we've come together, there's been more ideas that have been shared. And we know that by opening it up to the community, there may be even more ideas that we share. So please take some time to fill out the survey. We'd love to hear from you about your ideas as it relates to this work. Register for the public input session. That's also on the website, so you can do that. Again, this will be an opportunity to see the report in more of a draft form, where you'll start to kind of see the sections and the way in which these solutions are really written, and it'll be an opportunity to weigh in, to provide input. We want this to be something that the community feels like is representative of the ideas and input we have for really making some headway around improving maternal child health outcomes. And then finally, be on the lookout for more information about the release of the action plan. So we'll be releasing that during Black Maternal Health Week. There are opportunities to continue this work, and so that's happening right now as we're thinking through some opportunities to continue this work in the future. So that'll be something that we also preview as part of the event in April. So I think that's all that I have. I think that was my last slide. So I want to just stop and pause, check the Facebook chat, also the other chats, to see if there are questions or comments about the process that we can answer for you. Just giving some wait time. I know we share quite a bit, so just allowing folks to just maybe think through to see if we have any questions. So we'll give a couple more minutes for that. In the meantime, I'll just share that for tomorrow, we'll be back here tomorrow at 4 o'clock. You can join us again on Facebook Live, or you can visit healthystartpittsburgh.org, and you can check out the live stream there. And we'll be hearing from 3 more speakers tomorrow, and continuing to have conversations around maternal child health tomorrow. So that'll be happening beginning at 4 o'clock. And then again, you also see the information about the public health, the infant health equity public input session happening on March 15th from 5:30 to 7. You can register for that on the website as well. And that'll be an opportunity to provide some input on the action plan. Okay, so seeing no questions in the chat, we do encourage you to visit the website. Make sure that you take some time to do the survey. Please respond to register for the input session, and then we'll see you back here tomorrow at 4 o'clock for the second part of our town hall. We thank you for joining us today. We appreciate your time and engagement in this process.